This is Jonathan Angulo on July 31st, 2025 at 2:24 Central Standard Time at Dr. Norman Hearst's home, conducting an interview for the Global Oral History of PEPFAR project. To begin, could you start off by introducing yourself?
Yes, I'm Norman Hearst. I am a physician and epidemiologist, and I've been almost all of my career at UCSF, University of California, San Francisco, really. All of my career, really, starting as a medical student and in one form or another. And I'm still on the faculty there. I still work a little bit clinically part-time and do a few other things, but I'm mostly retired at this point.
Perfect. Please briefly tell us about yourself and your family. Where did you grow up?
I grew up in Oxnard, which is in Southern California, outside of Los Angeles. My parents were both from Germany, although I ended up doing a lot of international work, I've lived in California all my life, grew up in Southern California, then came up to college in Santa Cruz in the Bay Area and never really left Northern California.
So can you tell us a little bit about your transition from Oxnard to Santa Cruz and to UC San Francisco? Mm-hmm. And tell us about what drew you to the field of medicine.
Yeah, in terms of medicine, I was, kind of always a science STEM type person, and I know our family had a family doctor that we'd had for years and respected very much, so it seemed like a good career to aim for, and that's so I went off to Santa Cruz and studied pre-med there, and what got me to San Francisco was that happened to be the medical school I got into, which is a little ironic, especially nowadays, that that was the only one where I got in, or at least nowadays that's the most difficult one to get in, but that's where I ended up, yeah, and liked it there.
Yeah. Can you tell us a little bit about your specialization, maybe perhaps at UC San Francisco, or after that, focusing on epidemiology, biostatistics, community medicine?
Yeah, so I was family medicine kind of from the get-go. That's what I planned to do, and that's what I stuck with. And so after graduating, I did my residency in Fresno, California, which is out in the Central Valley, about 120 miles from here, and that is a UCSF affiliated program also. And I was kind of ready to go off and be a general practitioner or a family practitioner in the Sierra foothills near Fresno. I was picking out what communities I liked, but I was near the end of my residency, and I happened to be back in San Francisco visiting friends and visiting one of the professors I'd gotten to know when I was a student here. I'd worked with him on some public health research projects, and he says, you should talk to this guy, my friend Steve Hulley. He's just starting a program in clinical epidemiology here. Maybe you'd be interested. And to make a long story short, I ended up meeting him that day, and we hit it off well, and I was interested to be able to come back to San Francisco after my 3 years in Fresno, and I was interested in clinical epidemiology and public health, and so I signed up for that 2-year program, and it included getting an MPH, a Master's of Public Health degree at UC Berkeley as part of the 2-year fellowship. So here I was, by now we're in the mid-'80s, and I'm landing in San Francisco as this kind of young, eager, newly minted clinical epidemiologist right while the AIDS epidemic is hitting here in San Francisco. And there was sort of this golden moment when people recognized that this AIDS was this is really a big problem, and the government wanted to get involved, and they wanted to do AIDS research, and for a while at least they had more money than they knew what to do with, and the people at UC San Francisco were very happy to help them out with that. And it turned out that this guy, Dr. Hulley, who ran this clinical epidemiology fellowship that I mentioned, he ended up, I don't know whether through his initiative or whether he was asked to do it or invited to do it, but he pulled together a group of people at UCSF and other community-based organizations to put together an application for funding for what was called the Center for AIDS Prevention Studies. So this was to do research around prevention. We weren't going to be the ones trying to, discover a vaccine or it was all around prevention, which, yes, includes epidemiology, but heavily behavioral. So there were a lot of psychologists involved. And this was funded, and a lot of the research was, of course, with what we now, I believe, is still the correct term, men who have sex with men. At that time, we would say gay men or whatever, and injecting drug users, because those were the two big groups hit in this country, and then there were the transfusion recipients and whatnot. But that prevention there was a much different, almost purely biomedical thing of learning how to make the blood supply safe, whereas prevention and the other things, you were right into messy human behavior, things like drug use, things like sex. And so this center got started, and again, there was more money than they knew what to do with, and about a year later, so I was invited by Steve Hulley to be I think he called me his deputy director. It was basically, assistant to do, so help to write the grants and be involved in planning the research, and more as a technical resource. We were sort of the UC people who knew how to do Kaplan-Meier statistics or whatever, that sort of thing. And we were working with these community people who knew all about the gay community, but maybe weren't researchers, and trying to get things happening. But they came back, we'd really just got started, so it was maybe 6 months later, and they came back and said, why don't you apply for a supplement? Come up with some more projects. This was the feds, some agency called ADAMA, I believe it was called back then. Doesn't really matter but they were it was kind of the way that AIDS funding worked there. The government wanted to jump into AIDS research, but didn't really want to spend any money on it. So the approach was, they told all the existing institutes, well, why don't you start spending 10% of your budget on AIDS research, which in some cases, if it was the NIAID, which is infectious diseases, fine, but it resulted in some rather ridiculous things like money available to study the cardiological implications of HIV/AIDS, which I don't believe there really are any of any importance, but there was plenty of money to study it, because that's how the National Heart Institute, or NHLB, I guess Heart, Lung, and Blood, whatever it was back then, that's how they were trying to spend some of their money. But they came back and said, come up with some more projects. And Steve Hulley says to me, well, Norm, is there anything you want to do? And I was always interested in international health. I'd gone off and worked in a hospital in Guatemala while I was in medical school, and my residency was in Fresno, which was practically international health, because it was the county hospital there, and 90% of the patients were Spanish-speaking. The huge farm worker community there, and whatnot. And I'd wanted to do international work, but it wasn't clear how one would go about doing such a thing as a family doctor. They didn't need, unless you wanted to go off and be a missionary doctor or something like that, or join the Peace Corps. And I thought about those things, but they didn't seemed to make a lot of sense for me. I was starting a family and all that at the time, but I said, well, hey, let me put together an international program. Let's and I talked to a lot of people who ran things, and so the idea was to bring in people for a 10-week training in kind of a crash course in research methods. And these would be people from developing countries around the world, and we would help them in 10 weeks come up with a research project. They'd by the time they left, they'd have a research protocol, and we even talked the feds into giving us a little money, so we'd be able to give them $5,000 or $10,000 when they got home to do their projects. And $5,000 or $10,000 goes a long way in poor countries, especially when it's not really biomedical research. You can hire a lot of interviewers for $5,000, or you could back then anyway. And so that's how I got involved. So I ran this program for a little over 10 years, and we'd take 10 people a year. And these were people who had already, one way or another, demonstrated a commitment to HIV/AIDS. And some of them were quite high up in their national AIDS programs. We ended up with a few who ended up going back and becoming head of their national AIDS control programs, or they were doctors, they were psychologists, they were, in some cases, community activists, and they would do various projects. That the type of thing might be surveys, behavioral surveys, looking at who's at high risk, and we'd really encourage them to try to do some sort of intervention and measure what, if any, impact it had. So and I was mainly interested in Latin America. That's where I was it was almost entirely me running the program there. I had a colleague who was a psychologist who was more doing the Asia part. We didn't really have anyone to do Africa, so that's kind of when I started getting involved in work in Africa. So this is the 90s by now. That's the kind of 10 years I was running the program in the 1990s.
Before moving further, I wanted to ask you, obviously, your expertise, medical expertise.
Mm-hmm.
And for the common layperson, can you define what prevention is in the medical field?
Yeah. Well, so my clinical work has always been in family medicine, and I don't really have any special expertise clinically in treating HIV/AIDS patients. I mean, because of the work I was involved in, I maybe paid a little more attention to it than the average family doctor. And just being in San Francisco, I had patients who had HIV or AIDS, but they were also seeing an infectious disease specialist who was managing that, and I was managing the other aspects of their health generally. But what is prevention? Well, there are different types of prevention. There's primary prevention, secondary prevention, tertiary prevention. Primary prevention is if you can keep somebody from getting a disease to begin with. Secondary prevention is, even if they get it, can you prevent the harmful outcomes? And tertiary, that's another, we don't really need to get into that. But certainly with an infectious disease like AIDS, prevention is how do you keep people from catching the virus? And for HIV/AIDS, in theory, that's not so difficult, unlike COVID, where no matter what you do, they're going to catch it eventually. So all efforts to prevent it are futile in the long run. But for AIDS, well, you can just keep them from using needles, or keep them from having, you can have just one partner and be extremely unlucky and get it, but that's not how people get it. They get it. Occasional people do, but mostly the people in those days getting HIV/AIDS were people who had a large number of sexual partners. So in theory, it wouldn't be that hard to prevent. In practice, getting people to change any of these behaviors is, of course, extremely difficult.
Yeah, thank you so much.
I went off, I don't know if I ever answered your question, but yeah.
Especially going into um, secondary, and
Yeah.
kind of the different branches of that.
Yeah, just to expand a little more on the secondary, I mean, prevention is once people have got it, try to keep them from dying or try to keep them from getting sick, which when we started the whole thing, there was no way to do that. But then the antiretroviral drugs came in, and then there, you could actually, other than treating infection after infection, but not being able to do anything to restore people's immune system till they eventually die from something, then that changed everything. Then you could actually, if not cure, keep it into a treatable, long-term chronic disease.
We left off talking about your interest in Latin America.
Yes.
Searching for people with expertise in Africa.
Yeah.
Can you tell us about your knowledge of HIV/AIDS in Africa and how it evolved over the years? And also as well, if you want to kind of touch on Latin America, the Caribbean, etc.
Yeah, well, I can talk about Latin America, the Caribbean, much more quickly because, with a few exceptions, almost entirely the epidemic behaved in Latin America mostly like it did in the United States and remained concentrated in these certain high-risk groups. There'd be a few people who got it heterosexually, either they were sex workers or whatever, had a large number of partners, or they just were unlucky. But mostly, 90% plus of the cases in almost all the Latin American countries were in the same, we called them high-risk groups back then. It's funny how you come up with a name and then the name by itself somehow becomes stigmatizing, so then you change the name to something less stigmatizing. But it was in injecting drug users and men who have sex with men, and that's pretty much how it was in Latin America. In contrast, in Africa, although you do get some transmission, but a very small proportion of the total in these traditional risk groups, and maybe more through commercial sex, but you had these generalized epidemics, and it's the same virus, but landing in a different field, and you get self-sustaining heterosexual transmission in the general population. And so it's like, well, why did this happen in Africa? And it doesn't happen in any developed country in the world, or even in middle-income countries for the most part, like Latin America. Why is it just in Africa? And there's a combination of things, and there may be some other things. But really what it comes down to is just patterns of sexual behavior and just greater levels of, again, promiscuity is the word we're not supposed to use, but people just having larger number of partners. Of course, not everybody, but I'm sure you've come up with this before, but for transmission of a virus, we were hearing all about it with COVID, but it was maybe in some ways more important for HIV. You have this R, or this number that the mathematical modelers look at, and it's for each person who gets infected, on average, how many others will they infect? And if the number is less than 1, the thing gradually dies down. And if the number is more than 1, it will grow exponentially. So the difference between it being 0.8 and 1.2 could be everything. And for whatever reason, in certain areas, mostly poor countries of Africa, interestingly Haiti in the Americas, some parts of India, we got these generalized epidemics, which, because they reached the general heterosexual population, ended up becoming the vast majority of all HIV/AIDS cases in the world. And this thing really before anybody realized what had hit, because by the time you started seeing the sick people, the cat was out of the bag, and it was in the general population in high levels.
Perfect. Can you kind of gave us some context about what was happening in these different regions around the globe. Can you tell us how the pathway that led you to your first trip to Africa, and in particular, your first trip to Uganda, and where you focused much of your work?
Yeah. So when we got this program funded, we thought, gee, we better go up and find some we've got to take our first group of people in just a few months. We need to. So I did this whirlwind trip and visited maybe 10 countries in Latin America in a few weeks, and visited their national AIDS programs and said, hey, we got this program, send us applicants. And my colleague, this was in Latin America.
Yeah, I wanted to specify the program you're talking about, the Center for AIDS Prevention?
That was, that one where we took people for 10 weeks and trained them to do projects. Because the result of that was that we were providing technical assistance or helping them do these projects. I mean, in 10 years, this was 100 different projects all around the world. And I became involved in a lot of them, maybe most of them, and often did site visits and had these colleagues, these people who'd been there that I knew. So I went there and I had someone to see and to visit who connected me with the right people. So that's kind of how I kind of got to be known in the small or medium-sized HIV international health world. But when the program started, I didn't have any of these connections or anything. So there was a Dr. Ziegler, John Ziegler at UCSF, who was high up. I think he was the chief of medicine at one of our hospitals. And he had worked in Uganda at Makere, which is the main teaching hospital at the, actually that's the university, Makere University. The hospital's Malago Hospital. And he kind of knew the people there. And the first time I went there was to make connections, and we actually ended up taking several people from there to our program over the years. And I visited their AIDS wards where they had all these sick people wasting away that they basically could do almost nothing for. They had none of the expensive medicines. They had none of the, well, they were, that was maybe the best hospital in Uganda, but they had none of the equipment, none of the level of treatment that we had and have here. Yeah, I mean, the main impression of Africa, if you're not there as a tourist staying in swanky resorts, is just the overwhelming level of poverty and I mean, people living in thatch roof huts is the picturesque, romantic picture of it. They're morally living in squalor and filth and unair-conditioned cement block buildings in hot capital cities, and there's nothing glamorous about it at all, really. Yeah, so those were, I mean, I was trying to be out there where the problem was, and the problem seems overwhelming, not just HIV/AIDS, but just the whole plethora of problems.
Mm-hmm. And can you, to establish a timeline, can you tell us about, the year that you met John Ziegler in Uganda, and also as well, maybe like some of your memories, right? Working, introducing with him. And I should be clear, I never spent a lot of time working in Africa. I probably visited Africa not even that many times, 10 times, and I was usually there a few days. I was working with the Africans who were here in my program, and then I was working with them by email and internet and files. I met John Ziegler in San Francisco
I was with him in Uganda at least once, but I remember that. We went on ward rounds there once. And, you know, they all knew him. He'd been working there for years, and they adored him because he was one of the, you know, they had a lot of foreigners who'd come and go supposedly with altruistic motives, and they'd never see him again. But he was the one who kept coming back year after year, decade after decade, and they appreciated that. And he was able to connect me with the right people. And again, then that connection was, then they would come to our program, we'd help them design a research study, they'd go back and do it, then we'd bring them back again and help them analyze the data, write it up, get it published. Yeah, so that was, so I never worked in Africa for an extended period. I did, after I stopped running the program after 10 years, I did a sabbatical at UNAIDS in Geneva, and that will come up probably later in our interview. And I stayed there for 6 months and really got to know the international kind of AIDS structure very well then.
Yeah. So we're going to get into that in a little bit about UNAIDS, but before moving into that, I wanted to ask you about meeting Ted Green.
Yes.
And about that both of you did together. Can you tell us a little bit about that
Well,
story?
yes, and I saw that in your question, and it was like, when did I meet Ted Green? I mean, I know Ted well, and for many years we worked closely, and, you know, we were friends, we visited each other's homes. I cannot remember when exactly, where or when was the first time we met. Mm-hmm. I believe we were introduced through a fellow named Dan Halperin, and I think he should be on your list of people to interview if he isn't already. Mm-hmm. And Dan is a public health specialist. He's not a physician, but he worked in HIV/AIDS for many years and ended up working with and for Ted when he was running his AIDS prevention program at Harvard. But long before that, he was a fellow doing his fellowship. He's about the same age as me, so he was doing training at UCSF around the time I was, and so that's when we first met. And I'm pretty sure he was the one who introduced me to Ted, or who got us connected.
Okay. So again, going back to, in 2002, the UNAIDS commissioned you to conduct a technical review.
Yeah.
On how well condoms work when it came to HIV prevention.
Yep.
Can you tell us about how that ended up coming about?
Okay, so yeah, I had done this sabbatical at UNAIDS, and that was in 99, 2000, right about there. I mean, 2000, yeah. So at that point, I was, you know, I'd been there for 6 months. I was trusted. People knew my competencies. And they wanted, condoms were, I suppose they still are, but they were controversial then. And some people were saying, oh, condoms don't work. They have holes in them, this and that. It's just nonsense. They don't do anything. And all the people at UNAIDS, of course, thought, well, nonsense. Of course condoms work. We all know they work. They test them in laboratories and this and that. And they wanted to conduct, so they wanted, you know, to counter such arguments, the specific technical, the main thing they were thinking of is the technical argument that condoms have holes in them and don't do anything. They're just this invention that somebody thought was a good idea but don't really work. I digress, but kind of like face masks actually really and truly did turn out to be for COVID, something that was a bright idea that turned out didn't do a thing. But again, I digress. But people thought condoms were the same thing, that they just don't work. They're just made up for God knows what reason by the condom sellers or the pro-condom faction out there. So UNAIDS didn't want to just say, oh no, that's nonsense. They said, give them credit. Well, let's get an impartial party to do a technical review. And since a lot of this criticism, maybe it was coming from, or was maybe perceived as coming from those silly Americans, who better than get an American to do it? And they knew me, and they knew I wasn't an anti-condom person or from the religious right or whatever were their perceived enemies. Besides, they didn't want to spend any money on it, and I was the only person they could find who'd do it that cheaply. So they gave me like $10,000, which was enough to hire a grad student to help me with it. We went out and collected all the information we could. So you say, does something work? Well, there are a lot of different levels of that. But the first question is, do condoms work when used correctly and consistently? And obviously, you would have to be talking about a discordant couple where one is infected and the other isn't infected. Otherwise, you can't have transmission. And so, do they work, or are they just this nonsensical thing that doesn't work at all? So in epidemiology, we talk about effectiveness and efficacy. So that one of them is how, the efficacy is how well it works with perfect use, whereas the effectiveness is how well does it work in practical, common use. But the efficacy part, there was data from studies where they'd followed these discordant couples over time, and there were a number of such studies done in the world, a dozen or so, which sounds like a lot, but when you realize, I mean, it's really the only real data we have on whether condoms work, and you couldn't randomize people to use condoms or not. You maybe try to talk them all into it, but maybe half of them would and half of them wouldn't, and then you follow up and compare infection rates. And you put all that together, and yeah, the condoms work. Certainly not 100%, but depending which study and what circumstances, somewhere around 90, 95%, which is for some cheap medical device product, that seems pretty good. So that was the first part of the review. The second part of the review, though, was looking at, well, what's the effectiveness and how well do they work in actual practice? See, because these studies, they're based on, these are people, not only do they know they're in a discordant couple, they know they're not infected, they know their partner is, or vice versa. Not only that, they're part of a research study where people are bringing them in every few months, testing them, saying, did you get infected yet? Did you get infected? So this is absolutely, you couldn't imagine a more motivating situation to use condoms consistently, which is unfortunately not how most people use them. And it was amazing to me, and again, I'm not anti-condom or a condom skeptic for any reasons of principle or anything, but I had always been taught in my medical education that condoms are a practically worthless form of contraception. They're a lousy form because no one will use them consistently enough for them to work. And it was amazing to me how this thing that was ridiculed by the powers that be, because we had things that worked much better, like pills and IUDs, so it became politically correct to hate condoms for contraception. And then suddenly they became this wonderful thing that was going to save the world from AIDS when it suited the purposes of whoever was doing the talking to claim that, oh, we've got this great thing. So we looked at, well, what's the evidence for actual public health effectiveness? And there were some studies, for example, in sex workers. So you, like in Thailand, you go in and you make a law that you have to use condoms for sex work, or you run a prevention program and train all the women and hopefully train the clients who are maybe the ones who really decide or whatever. You can get some data showing that the condoms have some impact. Nothing like 90%, but they help. So in concentrated epidemics, there's some evidence in gay men that the ones who would use condoms or get their partners to use condoms were less likely to get infected. So there was evidence for public health impact. You looked at generalized epidemics in Africa and nothing. No evidence whatsoever that they would have any impact. You can't prove it's impossible to prove the contrary. You cannot prove something doesn't have an impact. But, studies that were done that expected to find an impact, and certainly a lot of condom promotion had been going on already, and you could look at timelines. There just wasn't. A lot of it was just lack of good evidence one way or another. But we had to conclude in our report that there was no evidence that condom promotion had any measurable effect in places with generalized epidemics. Mm-hmm. And that was our report.
Yeah.
Because that's what we found.
Mm-hmm. So what were your feeling about the findings? Were you surprised at all or not?
I was surprised. And, some people had kind of been trying to tell me that. People like Daniel Halperin and others. And, me being out of San Francisco, where the condoms were the big strategy for gay men and seemed to at least be doing something, that wasn't really what I was expecting. I wasn't surprised by the first part, the efficacy, the theoretical efficacy part, but I was surprised. I was expecting to go out there and find at least some evidence, and we didn't. This was maybe UNAIDS's mistake because I was one of their guys, but I never worked for them, and by that point I was back out in San Francisco, and I didn't have to please them with what I said. I mean, they'd given me a little money I hired a research assistant with, but they had no leverage over me at all, and they were quite upset. And Peter Piot, who ran UNAIDS, and who I knew before he ran UNAIDS, who'd worked with me a lot in this program that I'd set up, and who welcomed me there to do my sabbatical, and we were on a first name basis and often in meetings together, and respectful relationship, got along just fine. He stopped speaking to me after this. I mean, it was, to me, childish, excuse me. I mean, we'd meet at these national AIDS conferences and he would pretend he didn't know me and walk right back. I mean, to me, this is the behavior of school children. But maybe he was right. He was a good scientist and a very astute person politically, and he probably figured it wouldn't do for him to be seen talking with me. And we never spoke again.
Yeah, that sounds difficult and hard.
Yeah.
Can you tell us about where and how these findings were published? Again, you kind of already talked a little bit about it.
Well, I mean, we wrote a report and turned it into UNAIDS, which they shelved, and on various occasions denied existed. This was probably individuals who didn't really know it existed. I don't think they were flat out lying, but I was told by many people when they asked about the report that people told them there was no such report, and that I'd never worked for them and this and that. That report happened, but we were determined to publish it in a medical journal, and it was almost impossible because it was not politically correct. So peer-reviewed journals and their peer reviewers all hated it, and we got it rejected in several places. And we're finally able to publish it in a family planning journal because I think the family planning people knew all along that condoms don't work very well. So that's where we eventually published it. But, you know, word got around, people heard of it, and we were not the only ones saying that. And eventually there were, you did get some dissenting viewpoints out there over time. Mm-hmm. So we're part of that. You know, you can try to suppress evidence for some period of time. Suppress evidence is too strong. You can ignore evidence for some time, but eventually at least some people will start talking about it and things will get more known.
Mm-hmm. So the next couple of questions focus on ABC, but before going into that,
yeah,
I wanted to ask you, you know, you're going into UNAIDS, you're commissioned to do this study about the effectiveness or efficacy of condoms. But what was your sense of the United States and its intervention and interest in addressing HIV globally during that period and AIDS?
Yeah. Well, so I was very attuned to who's funding international AIDS research, particular training, less attuned to kind of generally what was happening on the ground in terms of who's funding taking care of sick people. So what was happening before PEPFAR? So AIDS, for whatever reason, really grabbed people and got their attention, maybe their imagination, and this is something that kind of, even though I was working in AIDS and in a way was a beneficiary of it because I could get projects funded, I never understood why it just bothered people in America and other rich countries, but especially in America, I don't know why. It just bothered them a lot more that people were dying of AIDS, but they couldn't care less that they were dying of malaria or dying of tuberculosis or dying of malnutrition or dying of all the other things people were dying of in Africa. And even before PEPFAR, people were, I don't know what Washington was spending, but people were, you would see a lot more in newspapers, you would hear a lot more call. People were worried about AIDS in Africa. They were worried about it. As well they should have been, but still didn't explain, so why aren't you worried about malaria in Africa, which is killing a lot more people every year or whatever. But yeah, and I don't claim to know George Bush's personal motivations or the motivation of the circle of people around him, but and you know, but I think they, for whatever reason, decided they wanted to jump in and do something about AIDS in Africa. And initially, PEPFAR came down right around the same time that the effective AIDS treatments were becoming available on a massive scale. So the first country to provide universal access to AIDS treatment in the world actually was Brazil, not some rich country. And they did this around 1995. And the people running the AIDS program at that time, many of them were my friends who'd been in my program, and I was able to help them to show that, because I think the feeling at first is, well, we have these antiretroviral drugs, but they're horrendously expensive. And you need all this advanced technical, medical knowledge, medical capacity, all this, you need virological labs, and you need CD4 cell count machines, and you need all this technology to use them, and they're ridiculously expensive. So they're great, but this is not going to be something you can use outside of rich countries. And then Brazil and others came along, and first Brazil, followed by, I think Thailand was next, but middle income countries just said, well, we're just going to do this. And by God, it worked. Even if you didn't have all those fancy machines, it turns out you could give out the drugs, and maybe you weren't doing it 100% by the book, but that didn't matter if you were doing it, if you got it right 90% of the time. And we were able to show just huge differences in how many people were dying. And so, and I think that also sort of heightened the awareness of the inequity of HIV/AIDS, that we did have these drugs that could at least keep people alive. It wasn't clear then that you'd be able to, keep them alive, most of them, till they get old enough to die of something else, or basically for a lifetime. No one really knew how long the treatments would last, but we knew all these people were dying who you could keep from dying, and that sort of hopefully rankles people a little to ask. And I remember I was at a meeting of I don't remember, it was the name of it, but it was sort of our National AIDS Committee. Ted Green was a member of it for a while, and I think he invited me to give a presentation, and I was at the meeting, and there were talks going on, and there was one guy on the I think he was the CEO of Pfizer. I'm not sure of that, but I think he was, but he was certainly a very high drug company executive. And then there was some other guy in the committee who was African American. I think he was a minister. He was on the committee, and they were talking about the antiretroviral drugs, and all these people dying in Africa, but they didn't have access because they were so expensive. I remember the minister was saying that people have to get their creative juices flowing, and we know how to make these drugs. We have to figure out a way to get them to these people in Africa, even if they don't have any money to pay for them. And to my big surprise, the CEO of Pfizer got up next and said, well, some of you may be surprised to hear this, but I completely agree with you. And I think that those conversations were happening. And so when PEPFAR came out, it wasn't like no one else had the idea, but the point was, the drug companies, they're not going to make their money out in Africa anyway. There's no money to be made there. So let them make their money in the rich countries, but let's figure out a way to get these drugs cheaply to Africa. And that was right around, and if PEPFAR hadn't happened, something else would have happened. There was this, that people of good intentions could see that we had to figure out a way to do this. And PEPFAR was by far the biggest single way in which that ended up happening. The problem with that, from my point of view as a prevention person, was, well, yes, you don't want all these people to die, but so you start putting them on treatment, but if you don't do anything prevention, what's going to happen? More and more and more people will get infected. Even if you keep them alive, you'll have more and more and more and more people needing these drugs to stay alive. It wasn't clear at that point whether, as fortunately did turn out, that would we be able to stay ahead of the mutations, or would they be kind of like cancer chemotherapy that keep people alive a few years, and then you move to your second line drug and your third line drug, but they all die of it anyway, and it's good they live a little longer, but what are we doing? You know, we rushed into this, and any dollar you spend on that rather than prevention, if you could keep them from getting infected, clearly you save the lives. And so that was the perspective I was looking at it from. And back then, UNAIDS was telling every country that you need a national AIDS plan. You have to have a 5-year plan. And everybody did this. All these poor countries, they did what UNAIDS said. They'd come up with a plan, they'd have a budget, they'd coordinate a donor meeting, USAID or whoever would be one of the people at the table, and they'd try to give them money to do this plan. And they used to say, well, because even before they really had drugs to the effective antiretrovirals, you have to do treatment, you have to do something for these people. You can't just say, well, you have AIDS, we'll just let you die. So the money would tend to get siphoned off to that and into the public health bureaucracy and whatnot. But they at least said, well, spend at least 20 or 30% of your budget on prevention. To me, it should have been higher because we didn't really have much treatment then. And then the same thing with PEPFAR. And there were those of us who were really pushing PEPFAR. Please at least include prevention. And they did. And I think it was around 20%. I don't know the exact numbers. So again, if you quote me, say it's my guess, but I think about 20% of the money for PEPFAR was supposed to go for prevention. Mm-hmm. So then the question became, what prevention? What do you do for prevention? So to back off for a second, I said, you know, I got to know the international HIV/AIDS muckety-mucks in the world and some of them in the key agencies. And certainly in San Francisco, I knew the people working with HIV/AIDS. I don't happen to be gay myself, but maybe most of the people who were really into HIV/AIDS were gay men. Out of the most wonderful of motives, they wanted to save their brethren. But the problem with this is that prevention got, the relation between that and kind of human rights became this funny thing. And Jonathan Mann, who was the first head of the AIDS at the UN, and he really made it clear that he was going to put front and center human rights, that HIV/AIDS response was going to be all about human rights. And I actually respected him for that. He died in a plane crash, tragically, just a few years later. But it became this thing like you couldn't tell gay men that it's maybe not a good idea to have, you know, a new partner every day in the middle of a raging AIDS epidemic, that was anti-gay, that was somehow anti-human rights. And so that the kind of guiding principle became, don't touch sexual behavior. Well, if you're not going to touch sexual behavior, what can you do for prevention? Condoms were just about it.
Mm-hmm. Can I jump in real quick? Because we're getting into prevention and ABC.
Yeah.
But before going more specifically into that, and you've already mentioned PEPFAR, but can you tell us, how did you feel maybe when you heard the announcement of it in the State of the Union? And how did you understand like the initial launch of PEPFAR?
Yeah, so I don't believe that I saw it in this, I don't think I was watching that speech, but it came out in the paper and, you know, it was, okay, gee, looks like Bush is really going to try to do something about AIDS in Africa. Good for him. You know, I wasn't a Bush supporter or Republican. It was your typical Bay Area Democrat and all that, but it was like, oh, okay. But again, I was on the research side, and I don't think I had any sense of how big it was going to be, that it really was going to be a game changer in a certain sense. And I had mixed feelings about it. I mean, it's great that we want to do something about AIDS, but it's kind of like what I was talking about before. And I had, recently done my public health epidemiology training and had been reading on international health and all. And at that point, generally the main school of thought was against these vertical programs. Vertical program where you pick one disease and dive in and say, I'm going to cure this disease. Because there's so many other problems in these African countries that to pick just one thing and focus all these resources on it, it's kind of like taking a balloon and pushing in with one finger. And yeah, you can push in as far as you're willing to press, but you don't really change the overall volume of the balloon. You just, all these other problems going on, and that at least the general school of thought was, if you have $100 million to spend on a healthcare in a poor African country, that you'll get far more bang for your buck if you just help them with building basic sanitation and basic health posts and basic access to care for simple things. So it was like, well, good that they're going to do something for HIV/AIDS, but yeah, well, it's just the fad now, and they're responding to the fad when, and people wrote scientific articles on this and about how if you took that AIDS money and spent it on tuberculosis and malaria and other things, you'd save far more lives, at least according to their models. Now, whether that's really true or not, I don't know. So to me, it was like, okay, you're picking, what was it, 5 countries, 7 countries initially. You're picking 7 countries, you're picking one disease. Well, that's kind of far away from, my ideological bent, which is let's go save the world. I still believe such things might be possible back then. Do I still believe it? I don't know. But anyway, so I had mixed feelings in that sense. And then the question was, well, because I wasn't involved in the direct clinical care side of things, so then the question was, well, is there going to be any money in here for prevention, and especially for me, any money for research into how to do prevention, because that's what we were doing. So, and the latter never really happened, I don't think, and that was really a shame, because PEPFAR, even though they spent a minority of their money on prevention, were still spending more on prevention than just about anybody else, but they never did any rigorous research into what prevention worked and what didn't and what was effective. And there were a lot of reasons for that. Probably the main one being that PEPFAR was never envisioned as a research project. That's probably the main reason. But also there was a lot of resistance. It was very hard to get people to do research, because the condom people didn't want you really to do research questioning whether condoms were working. And, the A and B people didn't really want you to do research into whether their approach was working either, because they all knew they carried God's truth with them, both sides equally believing that.
Mm-hmm. So can you tell us a little bit about how maybe you learned about ABC and its association to PEPFAR? And then you already talked about religious groups right now, but
yeah,
did you, what did you think was the role of like the religious right in addressing HIV/AIDS globally?
Well, as somebody who, after doing this report saying, condoms don't really work in generalized epidemics, the response I'd always would get, and I would always be uncomfortable with, is what instead? So then I would go back to, well, look at Uganda, and I'm sure Ted Green talked with you about this, about how they cut their HIV infection rates in half purely by getting people to change their sexual behavior with the whole zero grazing campaign. Now, this was very special circumstances, and maybe you can only get people to change their behavior when they're scared to death of dying, and realistically so. Maybe you have to all lose cousins and aunts and uncles before you'll listen and change your behavior. So whether that would work in other places, I don't know. But it worked there, and it worked in other African countries. You would see delay of sexual debut, you would see lower numbers of partners on average, and the rates would go down. So when people always ask me, what instead? And I know now, looking back on it, I shouldn't have taken the bait, because there was this logical fallacy. It was like they were saying, well, unless you have something better, then that shows you're just, nonsense, and we stick with condoms. And I don't know why I've sort of bought in with that, I have to come up with something better. The point was the condoms didn't work. Well, they didn't work, and they don't work whether you like it or not. And they don't work whether you have something else that works better or not. So we ended up arguing, well, you've really got to try to address sexual behavior. Not people like Ted Green and me, not for any religious reasons at all, or even ideologic reasons, just as epidemiologists. It's just like, are you going to attack lung cancer without addressing cigarette smoking? And that was what people were doing. It was like they were attacking lung cancer, and all you could do, you couldn't talk about whether people should smoke or not, because that was stigmatizing. As if you said you wanted to prevent lung cancer, but you didn't want to stigmatize smokers. So it would be wrong to say anything bad about smoking or being a smoker, because that would stigmatize people. And you couldn't tell them not to smoke or even to smoke less. So all you could do was try to come up with the best possible filters you could to put on the cigarette, and that was the standard human rights approach to prevention. I forget the question that you asked that I started talking in that direction on.
I think it's pretty
Yeah.
good.
No, so that's why I just seem being foolish and naive that well, gee, if these places with generalized epidemics, why do they have generalized epidemics? Well, because they have different patterns of sexual behavior, and there may have been other things that aided transmission, like higher rates of other sexually transmitted infections that make HIV more transmissible. But, well, why do they have higher rates of those infections as well? But that you really need to address the behaviors spreading the illness, and you really need to tell people that it's not a good idea to have lots of partners or casual partners in a place where 10% of the population is infected with HIV. This is just not a smart thing to do. You probably shouldn't really ought to do it. Mm-hmm. And that is A and B. And maybe you tell teenage girls in Africa that, your teenage girls are the group getting the highest infection rate, and maybe it's a better idea just not to start being sexually active, to wait a while, because otherwise you have a high chance of getting infected with a fatal disease. So you call that abstinence. B is, they had to find something that fit into A, B, C, but it just meant be faithful or have fewer partners or whatever.
Mm-hmm. So I kind of want to go a little bit into your testimony for the House Foreign Affairs Committee.
Yeah.
That was in 2007, and it was in regards to PEPFAR's reauthorization.
Yeah.
And we're having this conversation about prevention, and you stressed that prevention was key to that. Can you tell us about what was going through your head as you prepared your remarks?
Well, I think it was the same thing we were talking a little bit about before, that the key thing to the AIDS drugs worked, and you could see the lives you were saving, or at least for now saving, with it, so that it made this huge tendency for everything to be about treatment. And I think the crossroads that I was talking about there, and I didn't remember that I'd used those words, but I'm sure you have it right, was we can't forget prevention. We can't just go 100% into treatment. We still have to think about prevention, and that was sort of the crossroads that those of us advocating prevention really felt we had to make that argument. I think also maybe part of the problem was there was no criticism ever of the treatment stuff. I mean, no one came back and wrote, bitter op-eds about how PEPFAR should have used this slightly different treatment strategy instead of that one. No, it was all wonderful. It's treatment, you're saving lives. Prevention, everyone got upset because people weren't doing prevention the way they thought they should. Prevention was dirty. Prevention was controversial. Prevention, whatever you did that had any chance of having an effect was going to offend a big class of people. And so it would have really been the easy road to just say, well, we'll just make PEPFAR about treatment. Mm-hmm. And I don't think they ever did that. I didn't really stay that active in that field afterwards. So I do not know whether PEPFAR today still does prevention. I could not tell you whether they do or not. I don't know. I don't know 10 years ago, but I do know back then that they were one of the, at least in the countries where they were active, were one of the, if not the main source of funding to do AIDS prevention work. So that was very important, and I didn't want that to go away, and I also wanted it to be done in a way that would be effective.
Mm-hmm. Can you tell us about the importance and the effect of in-country participation, the role of local leaders when it comes to the ABC model?
Well, it's just absolutely fundamental. I mean, if you look at the record of foreigners going in, no matter how much money they have to spend trying to tell people what to do and get them to do what they want, you don't have a chance. The only chance at all is if it's local people telling them that. They're not, if they're going to reduce their number of partners, I mean, you can question whether they'll listen to anybody and make an argument that they won't listen no matter who tells them it, but they're a whole lot more likely to listen if they're hearing it from their compatriots and people who really believe it, not just people who are saying it because they get a nice job with a Western-style pay scale to be part of this aid program. And the people who have those jobs, they're not going to go criticize their funders or work against them. I mean, they're just they know how lucky they are to have jobs like that. So. Mm-hmm.
So
sorry, what was the original question?
We were talking about in-country participation.
Oh yeah, you absolutely have this, and young people are not going to be abstinent because sorry, I'm not trying to speak badly about any religion, but because Mormon or Baptist or whatever missionaries are out there telling them to do it, they don't care. But maybe if they're would they listen to their pastor? I don't know. Their pastors may be saying that already, but has some real strong reasons to go along with it. Would they believe their government? I don't know. Would they believe their friends, their family? It has to be a message that they're getting repeatedly from credible sources before it's going to, have any impact on kind of daily behavior, especially something as difficult to get people to change as sexual behavior. Mm-hmm, mm-hmm. See, I say difficult to change, it's difficult to just step in and change, but there's huge variation in sexual behavior around the world. And there are places where, I don't know if there still are, but there were places where the majority of people would have only one partner for their whole life, and that was normative behavior. And there are places where it's just normal to have just a lot of casual partners. And so you can't say nobody listens because people are born. I mean, it must be because they listened to somebody. Something affected their behavior, but how you make it has to be in the context of what's normal in your culture. And that's was probably why it could work in Uganda, because it was, the president and people were dying right and left, and everyone knew that he just stepped in and said, well, zero grazing. You just can't go out of your family compound for sex because you can't. The lion's loose out there. And not everybody listened, but a lot of people did, and it made a huge impact. But that wouldn't have happened because George Bush said it and said, I'll send $1 million so you can convince everyone to do it. Yeah. But you can ally with local forces who are trying to do this kind of work, who could never get any help to do it from outside. So yeah, you can't go in and say we're gonna set up an abstinence program or a less partner program, but you could support local people who want to do that in the context of this raging epidemic where people are dying. At least that's what I believed. And that I believed that would have a bigger effect than just hand out a lot of condoms and tell people, do whatever you want, have a great time. Just use one of these condoms. And some of the pamphlets and the TV spots and whatever that were funded with USAID money were we would have never let them put stuff like that on the air here. It was like, kind of telling young people, oh yeah, casual sex, that's fine, have lots of fun, but just use the condoms. Anyway.
Yeah. So I want to move forward and talk about your participation on the Subcommittee of Africa and Global Health in 2010 and its investments in the United States investment in HIV and AIDS. How did that come about? And what was the thrust of the remarks in that?
So, yeah, I mean, I ended up testifying to congressional committees a few times, and as I mentioned, the National AIDS Commission. I have to say that all of these are kind of blurred, and I don't, without really going, I don't even think I have the records, I don't remember exactly what I said at this place as opposed to what I said at that place. And when I was called as a expert witness at these events, it was always ironic to me that I was always called by the Republicans. Democrats never, I was a lifelong Democrat, but they never wanted to hear the kinds of things I had to say, so that was kind of interesting to me. But, seeing myself as a scientist, I wasn't going to get into, I wasn't going to censor what I was going to say because of the politics involved. I was going to say what I believed was true. And I still believe that's what you have to do as a scientist, because otherwise you're going down a really precarious path. So I would come and speak. And so which committee was this one that you're asking about particularly?
The Subcommittee on Africa and Global Health.
This is a House committee?
It's a subcommittee.
Of a House committee?
Yes.
Okay, because there was another, the time I remember the best was when I testified to the Senate Health Committee, and I remember that well because Ted Kennedy was chairing the committee, and I remember that well because my UNAIDS colleagues were the other witnesses who would speak to me in the hallway, and that one I remember the best. But I do remember, I think that's the one Tom Lantos was chairing.
Yeah, tell us about that.
Well, he was depending on where I lived at times, was my congressman. But I still think I said pretty much the same thing in those different testimonies. I don't remember that I said much different, and I was there because I wasn't called as the expert witness to say that condoms don't work. I was called as the expert witness as some sort of a credible academic person with global health credentials who would say, no, ABC isn't stupid. ABC makes sense. And we should be talking about delaying sexual debut, and we should be talking about having fewer partners. And I was never opposed to, and am still not opposed to, distributing condoms. And yeah.
Okay. So, going off on that, what are your views? And these views might have changed, but is PEPFAR still an emergency? Or
well,
is it
and as I said
that's...
then, I want to say one more thing because your questions won't get to it, and I was leading there. And I remember I said that when I said, well, condoms don't work, people would always come back with me, well, what does work? As if I couldn't come up with something else that did work, that meant that, yes, condoms do work. And I was trying to say, well, we've got to get people to change their behavior. Well, it never caught on in the way I would have hoped it would. But what happened then was this whole treatment as prevention thing. And then when it became clear, because no one even thought this, no one talked about it. You were treating them to keep them alive. Well, then it turned out, well, if you treat them effectively and you suppress their viral load, they're not going to infect other people. So all the time we were always saying, and no one would argue with us, you can't treat your way out of this epidemic. We would keep saying that. The more people you treat, the more people you'll keep alive with AIDS. You'll just have more people with AIDS, and it's great that you're keeping them alive, but it's not going to solve the epidemic. While more and more people are getting infected, and even the ones that are infected are still infected, you'll just have this bigger and bigger pool of people that you got to keep on these, what were then very expensive AIDS drugs, just to keep them alive. And okay. Personally, I thought it was impossible. It would all break down. Well, they managed to make it work, and they were lucky in that they were able to keep ahead of resistance with newer drugs. So it wasn't like you could only keep people alive for a few years till their virus got resistant. And when their virus got resistant, there were other backup drugs, and the new drugs came out fast enough to replace the old ones. So you really could keep people alive almost indefinitely. That was the one way they were lucky, because we didn't know that going into this. The other thing we didn't know is that, well, you still can't treat your way out of the epidemic completely, but if you can find everyone who's infected and get them all on drugs and suppress their viral load, you can't you can pretend that you could stop transmission that way. And that's what UNAIDS wants now. It's 95, 95, 9. Prevention is all about finding everyone who's infected and getting them all on treatment. So the outcome of the ABC battle ended up being none of the above. The outcome ended up being treatment as prevention. Insofar as it works, I guess that's not a bad outcome. It doesn't work. I mean, they've been saying in San Francisco that they're going to eliminate transmission, and they have unlimited money to do it because they're a demonstration site. And the feds for many years said, what do you need? And if someone gets infected and tests positive, they've got them on antiretrovirals the next day. They have caseworkers that go out and find them and track them all down and keep track of them and make sure they're still in treatment. They still haven't been able to stop transmission. They've cut it back. But, they were down to 200 cases a year. They said, oh yeah, within a few years we'll stop all transmission in San Francisco. Well, 10 years later, they're still at 150 getting infected a year. You can't completely treat your way out of it, but that's been the approach adopted because it does work, there's evidence for it, and because it's politically correct, and because no one gets mad at you for doing it.
Mm-hmm, mm-hmm. So when would you say that this shift happened?
And I've kind of been out of the HIV/AIDS thing for at least a decade now. But I would say that this the evidence that treating could, the way you first started seeing it is a few brave local gay serving organizations started telling their clients, well, if you're on the drugs and your viral load's undetectable, you don't have to worry about infecting people. You don't have to use condoms. Oh, they love that. And that was real controversial. But and I'd say that all started hitting about 15 years ago now, that became a thing that anyone would be brave enough to say. And then that became adopted. So maybe it's even more than 15 years ago. And then you got these 90-90-90 guidelines from UNAIDS, and then now it's 95-95-95. And you have countries that are getting close to these 95-95-90. It doesn't stop transmission. They still have transmission, but they have less transmission. And it certainly is a legitimate form of control, and it's certainly hard as it is to get people to take their anti-HIV drugs. It's a lot easier than getting them not to have sex or to use condoms.
Mm-hmm. And would you say, because you talked about San Francisco and the approach being in San Francisco.
But no, then it kind of moved on to the international screen, and then you started seeing the term TASP, capital T, then small a, capital P, treatment as prevention. The idea that you're treating them not only to treat them, but to suppress their viral loads so they can't infect other people.
Mm-hmm. So now that we've kind of got it through the questions, we want to go into kind of some reflection concluding questions.
Yeah.
So how do you find PEPFAR influenced the way you think about public health and global development?
Yeah. Well, I mean, as somebody who is a critic of PEPFAR in some ways, many times, and didn't really like the idea of one new massive vertical program when really what we needed was to strengthen the health system of these countries in general and all that. But, it worked. And I remember I was teaching a class of UC Med students at one point, and when was this? Maybe 10 years ago or 12, and was saying all the kind of things I didn't like about PEPFAR, and one of the students got up and said, well, would you say that PEPFAR really did more harm than good? And it sort of took me aback, and I said, no, I wouldn't say that. So, I mean, it was a good thing. Could it have been better? Probably, but it saved a lot of lives. It had bipartisan support. God, something we don't see for anything anymore. It was, I mean, back then I could come as the witness for the Republicans, and the Democrats were interested in what I had to say, and they kind of realized that the Republicans had a point, mm-hmm. and maybe vice versa. Sure wish we could get back to that on a much broader scale, but anyway. No, I think PEPFAR was a good thing. I think thank goodness it was generally perceived as a success in this country, which is probably why it seems to be the only thing that survived the second Trump administration so far, as I understand it. I don't follow these things closely, but it seems to be the only thing that they kept going. And in Africa, oh my goodness, there are streets named after George Bush. I mean, if you believe in soft power, this was our best investment in it ever. And I'm overly simplistic, but to me, when America goes out and tries to help people, really without major ulterior motives in this case, I mean, yes, you could say the way it was run was done in a way that would benefit the U.S. pharmaceutical industry. Well, what do you expect? But no, I mean, this was something that was done with good motives for the right reason and did a lot of good. And I'm proud to have been a little part of it, even if I was maybe seen as a gadfly and a critic in some ways.
Mm-hmm. So a lot of Americans don't know about PEPFAR. Why do you think that is?
A lot of Americans don't know about anything outside this country, but they know more about PEPFAR than just about anything else America's done in foreign aid. Mm-hmm. Maybe they've heard of the Peace Corps. Mm-hmm. The next thing they're most likely to have heard of, more specific than USAID, which has now become vilified, is PEPFAR. And you say they don't know about it, but a lot more know about PEPFAR than just about anything else that we've done in foreign aid.
Mm-hmm. So what do you think is the thing that's most misunderstood by PEPFAR? And whose voice do you think is missing in the stories of PEPFAR?
Well, what was most misunderstood to me was the whole ABC thing. To me, the idea of the ABC, now you could argue about how it worked in practice, and a lot of kind of programs run by religious groups that were probably silly little programs anyway got funded by PEPFAR that probably did nothing. But a lot of condom, you could say the same about a lot of condom distribution programs. But I think the whole ABC thing was misunderstood. And people thought ABC meant abstinence only. And it didn't. And at one point they put some quotas and that some of the money had to go for A and B because, the minority went for prevention and most of the prevention money went for condoms. But they said, well, let's say at least some of it has to go for A and B. And then that got vilified into, oh, it's an earmark for these religious abstinence-only programs. And I never saw that on the ground. What I saw was that percentage, whatever it was interpreted as anything that wasn't just C. And as I said in my testimony, I don't remember where, maybe that was the Senate testimony, is I thought that the ABC earmarks did more good than harm. Mm-hmm. And I still think that was true.
And what do you think PEPFAR's future is?
Well, much as I am a fan of PEPFAR, my biggest concern with it's still the same thing. Why do we pay for AIDS drugs particularly? Why is it just AIDS we want to stop people from dying from? Why don't we pay for diabetes drugs? Why don't we pay for malaria drugs? I still have that problem, and I think the only reason PEPFAR survived is it does have a mostly well-earned reputation of being a program that worked and was appreciated and saved a lot of lives. And it's really hard to pull the plug on that. But on the other hand, it's been getting close to 25 years now, or are we going to continue buying AIDS drugs for Africa as an exception and just only that? It would just seem impossible to me that we're still going to be doing that 25 more years from now. It just seems just so illogical to me. But maybe we will, because people do a lot of things for historical reasons, and maybe that will become our legacy as the one piece that America took ownership for and took the leadership on, and maybe we'll still be doing that in 25 years, but it just doesn't really make sense to me why we continue to fund AIDS differently than everything else. I'm glad we do, but it still doesn't make sense to me. Never really did. Mm-hmm. I'm glad we did it, but it never made sense to me.
Yeah. This is the last question. Is there anything you feel I may have missed which you would like to further discuss?
Wow. Well, I think PEPFAR only worked for a number of reasons. It was a certain historical moment where it could be done. We had a president who wanted to do it, and you can, put whatever bad motive on it. Oh, bad George Bush wanted to leave some sort of legacy that he could say he did something good in the world. Okay, well, if that's why he did it, good for him. I don't know. But I'm sorry, what the question again was, what did we miss?
The question is, do you think that there's anything that we missed that you want to talk about more?
Yeah. So why did that start me on that direction? Or what did I want to talk about more? I think where I was going with that is it took many things that had to happen at the same time, including the guy as president who wanted to do it for whatever his motives were. But the other thing that had to happen was that the demand was there. And this was not some idea the Americans had. This was the Africans who they were desperate. And one of the scholars who was in my program, and I remember hearing him talk to a group about the PEPFAR program. It was one of these international AIDS conferences. And again, you talk about gratitude or soft power. And he was the head of medicine at Milagro Hospital at the time, and he was saying, we had all these AIDS patients, and it was pitiful. We couldn't do anything for them. They were dying. And then we got the drugs, and we could make them better. They got up and walked out of there, and it was so wonderful, and we are so grateful. And yeah, but it only worked because the Africans were begging for it. It wasn't something we decided we were going to take there for them. No, we were answering their prayers. It had to be on both sides, and it was. And as far as I know, it still is.
It's a lie. I have a question now, so that wasn't the last question.
Uh-huh.
Are you surprised? Were you surprised at the time? Are you still surprised at the extent to which this sort of division over behavior change, prevention versus treatment has persisted? It's because it's resulted in these sort of funny scenarios for you being called up by Republicans and being sort of peculiarly aligned with evangelical groups and that kind of thing.
No, I think it plays out in other diseases and in other ways. And I remember starting my public health training. No, this was even in medical school, in my first epidemiology class, which made me kind of interested in public health. And the professor got up and she had a little, we had these magic lantern slides, then the transparent overhead transparencies, and it was this thing of a sink overflowing, and all these people running around in mops, cleaning up the water where it overflowed. And she would say, yeah, but what you really have to do is turn off the water to the sink, and the whole thing of prevention. And just in general, this is, we've seen it in PEPFAR, but you see it everywhere in health where, in the United States, what proportion of the entire I think it's trillions of dollars spent every year now on health in the United States, and probably 99.9% of that is on treatment, and just a tiny, tiny little bit on prevention. And at least in AIDS, maybe we were able to get a few percent, or in some cases, at some periods of time before the treatments were big and expensive, we were able to get it up to 10 or 20%. No, if that division is always there, and it's always much more compelling to spend the money on the sick person in front of you than on a healthy person, just to statistically try to reduce their chance of getting a disease. So that is always there. And then the thing about AIDS is it's spread through all the most controversial of human behaviors: drug use, sex, and it was like, it was funny. We worked in this center, and we brought in these people and trained them, and we were all these technical people, and we were all talking about drugs and sex all the time, because that's what it was, prevention. And how do you design questionnaires to assess, to get people to tell you the truth, and how do you figure out how common anal sex is, and things like this that normally you never would talk about in polite company or any company. And you walk into one of our conference rooms, and maybe it would say anal sex in big letters on the top of the chalkboard, and no one would think twice. It's as if you said structural engineering because you were working on a bridge building company or something like that. But HIV/AIDS, because of who it affected, just attracted controversy right from the beginning, and always has. And given that, I guess it's sort of amazing PEPFAR could get going the way it did. And maybe it only could because it was in countries where, maybe if the epidemic had stayed concentrated in gay men and drug users everywhere in the world, that would have never been the signature international health legacy that any president would have tried to pick for themselves.
Well, thank you so much. Is that okay? Well, thank you so much for your participation.
Well, I'm glad you guys are doing this, and it's funny. You do scientific work, and I've been doing that, writing articles and that for 40 years, and you wonder if any of it's ever remembered. And your old articles, the funny thing is, the only articles that ever get cited decades later, it's never for what you found, because that's all old hat. If you come up with some slightly different method, then that's what might get you cited years later. But it's interesting that people are interested in PEPFAR years later, not just interested in PEPFAR now, but interested in this historical background. And I think it really is interesting. I can't think of another single global health initiative, maybe smallpox eradication, that, is sort of, again, whatever criticisms people have, universally respected for having at least made a difference. So I'm glad people want to look at that and see what we can learn from it. And I'm afraid that some of the main lessons will be ones that we have totally forgotten about now, the whole bipartisanship and being able to come together to the extent that we did, to even in this country, to try to help gay men and drug users. Yes, maybe we would have cared more if others had been the ones affected, but at least we did care, at least some, and tried to do what we could. So I think those are good lessons that efforts to help health, help other countries, help poor people are not necessarily futile. Maybe that's the biggest lesson.
Yeah, absolutely. Well, we keep on looking forward to pushing this project forward and interviewing more folks as yourself that were involved. So thank you so much, and we really appreciate it, and also for welcoming us too.
Well, and it was ironic, after this was set up and, it looked like PEPFAR was going to get canceled, and I thought, God, how ironic. They're going to come interview me right when it's getting canceled.
Yeah, I still made it.
For now.
For now. Yeah.
Thank you.
Yeah,
well,
thank
and
you.
maybe your efforts can be part of sustaining whatever parts of this should be sustained.
Yeah, absolutely.
That would be worth all the flying around.
Yeah. Yeah.